Massive rotator cuff lesions are for sure the most difficult kind of tears to treat. These lesions generally occur in much older patients, and they are often related to worse tendon quality. Anyway, large or even massive rotator cuff tears can occur in young patients, leading the orthopedic surgeon sometimes to quite challenging situations. And here I'm presenting a case of a very young man who uses to play soccer regularly as a goalkeeper. He has been playing soccer always as a goalkeeper since his adolescence, and when his trauma occurred, he was 39 years old. Also, he uses to smoke a lot, about 20 to 40 cigarettes a day. So this patient never had pain in his right shoulder, but all his problems just started when he had a fall in May 2011. He was in a soccer game as a goalkeeper, as he always does, and then he made a jump to catch a ball in a movement that was quite similar to the one we are seeing here in this photo. When he landed, he said he felt a very intense and sudden pain over his right shoulder, and the pain was so intense that he had to immediately stop playing soccer. He said that in the following weeks he was still with very intense pain in his right shoulder and inability to elevate his arm, and he went to see about 2 or 3 doctors in that following month, and he was told that he just had a simple contusion over his right shoulder. So this patient came to me in my office in July 2011, something about 2 months after the trauma, and he really didn't have much pain, but he was really very worried because he just could not elevate his arm and his shoulder, and he could not even rotate his right arm laterally. Immediately after I talked to him and after I examined him, I gave him the clinical diagnosis of a cuff tear, and probably a big one. I asked for an urgent MRI, and patient came back to me in office just after a week with his MRI. So this is his MRI. Here we see a coronal view in T2 revealing a large tear of the supraspinatus with probably more than 3 centimeters. And here we see a lateral view still in T2 revealing a large, quite massive tear of the posterior superior cuff, including all the infra and the supraspinatus with a normal subscapularis tendon. And here finally we see an axial view still in T2 revealing a full, complete tear of the infraspinatus. An arthroscopy was immediately indicated, and so this is his arthroscopy. Arthroscopy, here we're seeing the biceps that was really in good shape. We used the probe just to test the biceps anchor that really had no signs of lesion or a slap. Also, through the articular part, we could easily see a massive tear of the posterior superior cuff, the infra and the supraspinatus, so we fastly tested the biceps. That was really okay as we pulled it out of the biceps pulley, and then we immediately moved to the subacromial space to do some bursectomy, and we fastly put the camera in the lateral portal. So now we are seeing a massive tear of the supra and the infraspinatus with the camera in the lateral portal. Then we used the spinal needle to establish an anterior supralateral portal, and once the portal was done, we would have to test the mobility of the tendon. So we entered with a grasper device through the anterior supralateral portal, and then we first tested the mobility of the infraspinatus that was quite retracted but in a good condition with good tissue, since the patient was and is very young. We entered then through the posterior portal with a grasper also to test the mobility of the supraspinatus that was quite retracted but also in a good tendon quality. So we would have to perform some releases to gain some mobility. We did that first with electrocautery, working for the anterosupralateral portal, and then with a shaver to release all the adherences between the cuff and the acromion and the distal clavicle. Then we used a basket to remove the edges of the tendon that is a quite devitalized part, as we all know. And once the tendon was prepared, we would have to create a bony bed in order to reattach the posterior superior cuff. So we first put a very posterior anchor, a double-loaded 5.0 metallic anchor, and then using a grasper through the anterosupralateral portal, we entered with a bird beak through the posterior portal, passed the bird beak through the infraspinatus, and then in a retrograde fashion we pulled the first suture out of the shoulder, out of the posterior portal, through the infraspinatus. Then we would have to pick up that suture through with a suture manipulator through the anterosupralateral cannula to tie the first knot of the first anchor. Once the knot was tied, we would have to do the same thing. So we grasped the tendon again with a grasper in the anterosupralateral portal, passed the bird beak through the infraspinatus, and again, in the retrograde fashion, we pulled the second suture from the first anchor out of the shoulder through the posterior portal, and then we tied the second knot through the anterosupralateral portal. Once the knot was tied, we would have to cut it, and then here we can see that the infraspinatus was already fixed, but we still had all the supraspinatus and the transition for the supra and the infra to fix. So here we are checking the mobility again, and we can see that the tendon was really retracted. So we would have to perform some more releases, and now we are doing that between the distal clavicle and the medial part of the acromion with the supraspinatus to gain all the mobility that was possible. Then we reattach the mobility, and the tendon had gained not much. So at that moment we decided to do some ablation in the superior part of the supraspinatus to put the tissue in a better quality. And once we did that, we decided to medialize the footprint of the supraspinatus, because as we all know, we must do a tension-free repair. So we medialized the footprint about 1 to 2 millimeters, and then we entered with a second anchor, a metallic one, double-loaded 5.0 in the anterior part of the greater tuberosity. And then for the anterior portal, we entered with a spectrum device, and we grasped the supraspinatus with a grasper through the anterosupralateral portal, and we passed the proline with the spectrum in the more anterior part of the supraspinatus. We just pulled that proline out of the shoulder through the anterosupralateral portal, and in a retrograde fashion we passed the first suture from the second anchor through the tendon and out of the anterior portal. We isolated both legs of the suture in the anterosupralateral portal, and then we tied the knot. And here we can see that we reattach it. We started to reattach the supra, but in a tension-free repair. Here we are tying the first knot of the second anchor and putting a lot of compression in order for the tendon to heal. Then for the posterior portal, we entered with a spectrum device, a straight one, and passed the proline. We isolated that proline out of the anterosupralateral portal. The camera is all the time in the lateral portal. And then we passed in a retrograde fashion the fourth knot, the second suture from the second anchor, out of the posterior portal. We put then both legs out of the anterior superlateral portal and tie the knot. This is the second knot from the second anchor, and then we would have just to cut it. And this is the final construct. So here we can see the supra and the infraspinatus. They were both reattached in a tension-free repair since we medialized the footprint and the insertion. In spite of that being a traumatic lesion, I decided to perform an acromioplasty, and because I thought that that could benefit the patient, so then we did a very fast and simple acromioplasty, working all the time through the anterior superlateral portal, not to damage the suture. So here we can see that the coracoacromial ligament was already removed. For the anterior superlateral portal, we performed a very simple and fast acromioplasty. So now the acromioplasty is finished. And here we can see again the final aspect of the construct. The supraspinatus and the infraspinatus, they were fixed with two anchors in a tension-free repair, and at that moment the surgery was finished. So the patient used a sling, an abduction sling, for about 4 to 6 weeks, and then he started his physio in a very slow manner. It's very important to say that the physical therapy should be started quite slowly in large tears, and I personally start to reinforce my cuff repairs only after 8 weeks, even when I operate small tears and even when I operate younger patients. These patients, of course, can go to physical therapy just after surgery for analgesia and to gain passive range of motion, but I only allow rotator cuff reinforcement after 8 weeks. And when I operate large tears, I start rotator cuff reinforcement only after 10 weeks post-operatively. So this patient started his cuff reinforcement in physical therapy only 10 weeks after surgery, and he did around 40 sessions of physical therapy during 5 months. So this is his MRI. It was made 1 year and 6 months after surgery. Here we can see the posterior part of the cuff, the infraspinatus, with a good attachment in the greater tuberosity. Now we are going slowly, more anterior. We are going, from posterior to anterior. Here we can see the first anchor with a good reattachment of the posterior superior cuff. Now we are seeing another image showing us a really good attachment of the supra and the infra. Now we are seeing another image, and it's quite funny that in spite of this tendon having been medialized in the surgery, as I have shown, the MRI shows us an image that seems to give us the sensation that the tendon had a normal attachment in the greater tuberosity. Now we are seeing a final image in the coronal plane. Here we can see the long head of the biceps and the anterior part of the supra that was fully reattached. And now here we've seen some lateral MRI images, and on this image we can see the beginning of the posterior superior tendon, since the tendon starts in the AC joint, and in this image the tendon is just below the AC joint. And the tendon seems to be really in good quality with full coverage of the humeral head. On this other image, a little bit more lateral, we can see that a small gap appears on the transition of the infraspinatus with the supraspinatus. The gap really resembles a past lesion, and on this other image, even more lateral, that gap is really bigger. Anyway, considering the severity of the lesion, of the initial tear, and considering that this is a post-op MRI, and considering that the patient is absolutely pain-free, I really don't worry about this MRI finding. In my honest opinion, this gap was formed between the fixation of the infraspinatus with the fixation of the supraspinatus. And here we see some axial MRI images, and on this image we can see one of the anchors, and it's quite clear that the posterior superior cuff is really well attached in greater tuberosity. On this other image we can see also a full reattachment of the infraspinatus and the supraspinatus. On this video here, taken 18 months after surgery in January 2013, we can see the shoulder scars from posterior and the anterior ones, and clinically both shoulders were looking quite the same, with no atrophy of the right shoulder muscles. The patient can elevate both shoulders and arms with absolutely no loss of strength, as he says, and with absolutely no pain too. And also, the patient has normal external rotation of the right arm. On that day, in January 2013, the patient told me that he had already gone back to soccer as a goalkeeper. He said that he has already played for about 3 or 4 months now with absolutely no pain, and he's really trusting his shoulder. And personally, as his surgeon and as his doctor, I told me that the idea of he going back to soccer as a goalkeeper really scares me, but I cannot prevent him from going to the sports he loves. So we decided that the patient will go to the gym to do some exercises very slowly to keep his shoulder, his right shoulder, in a good shape, and that he will practice his soccer as a goalkeeper. Thank you.